Welcome back to PremierU's truck edition of peptides. I make that joke, but honestly, I think a lot in the truck, and so it's a good time for me to reflect and think about these videos of things I want to share. What I'd love to talk about is something called Thymosin Beta-4. So many of you may have heard of it. A lot of times you will see it combined with the idea of TB500, which, let me create some separation there. So Thymosin Beta-4 is an endogenous substance. It is something that our thymus glands make. We lose it over time as a result of the involution of our thymus gland, and so as a result, our production decreases over time. But it is a very prevalent substance. It's actually highly prevalent in platelets. So like when we do PRP therapy, one of those growth factors that we're looking in to go in and do repair and recovery and create recovery for that patient is Thymosin Beta-4. Very interesting. TB500 is a fragment and is responsible for a portion of what Thymosin Beta-4 is capable of doing, albeit a very important facet of it. It is not capable of creating all of the differences that Thymosin Beta-4 is capable of, and that is important and is a nuance that needs to be thought about when choosing an agent, depending on what it is that you're looking to do. So let's talk about those mechanisms. So Thymosin Beta-4, I'm going to try to clarify where I can. So Thymosin Beta-4 and TB500 both do this first part. After that, Thymosin Beta-4 leaves TB500 behind. So for this first part, it is a G-actin monomer optimization agent. So what it's doing is it's creating these G-actin intracellular pools. So G-actin is a motility agent. Whenever you have an injury, cells need to move across the cytoskeleton to get to that injury to create repair. There has to be delivery of nutrients to other agents, and there has to be movement. Albeit strange, we are a three-dimensional system. Even within our skin, even in that narrow frame, these cells have to be able to move. What TB4 is capable of is creating this pool of at-the-ready G-actin monomers. Those go on to polymerize these little legs and feet. They're called lamellipodia and filopodia. Very cool. It's very weird to think about cells as having legs and feet, but they do. They are little motility agents that allow them to move through the cytoskeleton to move towards a site that needs repair and recovery. Now, that's where TB500 stops. The TB4 moves on to have other facets to it. So there was something called the ILK-AKT signaling cascade, where you're upregulating metallometalloproteinases, or MMPs. What this is doing is it's creating a more stable basement membrane environment. In addition to that, it's also helping to create resilience of those migrating cells. So you want those cells to be able to move. That's the G-actin component of it. And you also want those cells to be able to survive the trip. You want to have anti-apoptotic, meaning no cell death, occur across that to allow those migrating cells to get to the destination and do their job without dying in advance. You got to stabilize that part, right? In addition, and this is very unique to highly metabolic active tissues, so things like cardiac tissues and renal tissues. There have been studies done on specifically cardiac tissues and the ability of TB4 to be able to stabilize the tissue formation. So in that, let's pick a post-MI stage, right, where there needs to be repair of those damaged, those ischemic cardiac myocytes. What you don't want to have happen in a very dynamic tissue is to have too much fibrosis. So TB4 is capable of stabilizing something called TGF-beta SMAD3. In a result of that, so that's transforming growth factor beta SMAD3. That cascade is very important for what type of collagen are you depositing. Changing the characteristics of that signaling cascade causes a decrease in the amount of type 1 collagen, which is the more dense fibrotic kind, and also something called fibronectin, which, as you would suspect, is more fibrotic. Again, you want tissues that are compliant. You do want a mixture, but there needs to be an appropriate or a better proportion of the collagen deposition, and you don't want to have too much of just dense, thick scar, particularly in a dynamic tissue, which the cardiac myocytes definitively are. So again, TB500 does not do that part. In addition to that, there has been evidence that we are capable of creating an upregulation of the progenitor cells in the cardiac setting. So cardiac myocyte progenitor cells are activated even in the adult utilizing thymosin beta-4. Very cool. And again, thinking about this as something that we lose over time. We talk about what is aging. I look at aging as basically loss of resilience. And in another way to think about it is you're losing the production of some of these agents that create resilience. Those things that help us when we're young and we're bulletproof. We lose them over time, and this is one of those agents that we know changes with time. Our cells don't have it available, and as a result, these protective mechanisms go bye-bye. So you will see TB500, thymosin beta-4 used very often with BPC-157, GHK-Copper, KPV. It's for this motility agent part, particularly if you're using that TB500. That can't be stressed enough, that the TB500 portion really only has to do with that motility part. So if you need those cardiac applications, if you need those other specific agents, we have to think about something like thymosin beta-4, which is a better utility agent for this. So I hope this information was helpful. I know it's a lot of science, it's a lot of signaling cascades, but I think that that part is important, and I want to get that information out there so that others can use it appropriately to help for them to pick their health optimization journey. So I hope you're doing well today, and I hope you have an even better night. Take care.